So this panel is also looking at the role of governments. This time we're going to be focused less from a political perspective, more from a policy development and administrative perspective on how we can utilise various tools, some of which that were developed through the programme, to actually get governments all pointing in the same direction in terms of tackling health inequalities. And to help us do that, we've got three speakers who are each going to give a short presentation. Christiaan Decoster, and then we've got Taru Koivisto, and we've got John Ryan, who you met earlier today. And I'm just going to introduce them each in turn. So first, Christiaan Decoster, who's Director General of Healthcare for the Federal Public Health Service here in Belgium, and who's going to talk about the challenge of engaging government colleagues and stakeholders and how the use of a health impact assessment approach has assisted policy development in Belgium. So over to you.
Thank you. Thank you. It's an honor to participate to this panel. And we created a discussion in Belgium to increase the capacity of building and stakeholders' involvement in healthcare. I don't know if it's work. Yeah, okay. The objectives were that we organized a policy dialogue with three objectives. First of all, to inform key stakeholders and create awareness about health inequalities at different government levels and across all sectors. As you know, we have different regions in Belgium, so it was necessary to work with them. Secondly, to secure commitment of the key sectors to join a working group to develop a national action program on health inequalities. And we were very curious to see if they would participate, all the non-health sectors, and it was a success. It's a success in the first part. There was 1/3 of the participants who came from the non-health sectors, and in the second part, even near the half of the participants. The third objective was to identify key messages and results to support this plan. What were the key messages? Very quickly. First of all, the health inequalities exist in Belgium. They are increasing and they are, of course, unacceptable. 2, health inequalities concern the majority of the general population, and it's therefore necessary to influence the social gradient. 3, each sector and each department can play a role in the reduction of health inequalities. 4, cross-sectoral collaboration is complex. It's a complex process, but it gives results. 5, health in all is a tool and can give structure to the cross-sectoral dialogue. 6, action is urgently needed due to the economic crisis we heard in the discussion. That were the 6 key messages, and what are now the results? We did a survey under all the health and the non-health participants, and the results of that survey were that, first of all, that the implementing of a health in all policy regarding health inequality is necessary, and near 100% of all the participants were convinced of that. The second result was that they were all agree, 92%, to create a working group on health inequalities within the framework of the Interdepartmental Commission for Sustainable Development. The third result was that they have mandated the working group to develop a national action program on health inequalities to do the follow-up of the plan and the evaluation. Outcome 4, using the WHO report on social determinants of health and health divide in the WHO European region as a framework and translate the recommendations of this report to the Belgian context. Outcome 5, securing political commitment of the Interministerial Health Conference. 6, creating synergies between the future working group on health inequalities with the other groups in the intersectional working groups, notably the poverty, the social cohesion and the sustainable development. Outcome 7, avoiding unnecessary duplication. The various governmental levels must reflect on how health in all can integrate within the existing impact assessments. Outcome 8, to increase capacity building, awareness and stakeholders' involvement, contact persons regarding health inequalities at the different administration at each governmental level should be designed. How we had then come to the political commitment? Well, the results of our survey were presented to what we call the Interministerial Conference. It are the different ministers competent for health in our country with the different regions, and they started their activities in June 2013. A second point that I must say, underline, that is that we have a royal decree since last year about sustainable development, and one of the objectives in that decree is that we want to reduce the health inequalities with 50% in 2050 as a long-term vision of sustainable development. As I said, our intersectoral working group started its activities, and the objective is now that he will present his plan, his action plan, at the end of this year before our interministerial conference. Thank you.
Thank you very much indeed. And now Taru Koivisto, Director of Ministry of Health and Social Affairs in Finland, on the way that they've gone about promoting a health in all policies approach. Over to you, Taru.
Thank you, Mr. Chair. Ladies and gentlemen, dear colleagues, it's a pleasure to be here presenting our experiences on health in all policies implementation. It has been an approach of Finnish health policy for a rather long time with a title of Health in All Policies or similar names. The latest development on Health in All Policies was a conference, Global Conference on Health Promotion, which was organized last June in Helsinki with WHO. The main theme of the conference was Health in All Policies, and especially implementation of Health in All Policies approach throughout government. And we tried to present their successful examples which were carried around the world, different kind of countries and different levels of development. We had 800, no, almost 900 participants from 120 countries, and the results of the conference were a statement which just now is discussed in Geneva in World Health Organization's Executive Board, so that we are trying to promote it so that also World Health Organization gives some support for member states in implementing health in all policies. So I have to return to Geneva rather soon after this panel because of that. So it was a statement, and then there will be a framework for country action, which is, we have drafted it for a long time with WHO, and it gives also practical guidance for all of us. And then we published a book, Health in All Policies, Seizing Opportunities, Implementing Policies, which is available in the... So very practical tools which we hope will support all of us in implementing health in all policies. Just shortly, the contents, what are the elements the statement raised, what we need for implementation of health in all policies. And commitment, political commitment, it's the first one which we need. Then we need structures, processes and resources. We need strong capacity in the Ministry of Health to engage other sectors of government. We need strong institutional capacity and skills to promote health in all policies. We need accountability mechanisms. We need also measures to establish on conflict of interest questions, and we need to include communities, social movements and NGOs. So these are the elements which are now going to be part of a resolution there in WHO meeting. But this is not all we have done on health in all policies. It was a priority of Finland while we had an EU presidency in 2006, and it has been one of the approaches of our public health program since '86, and also the latest one including very strongly inequity perspective. So we have had long-term commitment, long-term vision, but I have to admit that results, these are not perfect. We are still working, we have still a lot to do, but however, we are working on this area. We produced an action plan on health inequalities a couple of years ago, and our lesson from that was that it was very good expertise, very broad approach in preparing it, but we didn't get enough political support. So that's something which is needed to have this approach implemented properly. Then we need the other sectors. We need multi-sectoral cooperation. What are our experiences, what we need, and how to create awareness, understanding, commitment from other sectors? We have to increase understanding that health inequity has a lot of influences on productivity, children's learning, functional capacity of older people, etc. So for other sectors, perhaps health and health equity are not priorities. They don't find them important, and therefore we have to find something in common challenges, common problems, common ways to work towards same direction. We are speaking perhaps on different issues and different items, but there could be perhaps even the same problem or same challenge. So languages are different, and if we want to work with other sectors, we have to provide them some guidance, tools, mechanisms. It's not self-evident that they take health into account if they don't have any practical help there. For example, checklists or fact sheet or well-prepared information on trends. So we need such kind of support for them. We have, however, some good examples about multi-sectoral cooperation, and sometimes we have found that it's easier to proceed if you are taking up some issue, so that it's more concrete, more easy to tackle. And one of that kind of examples is nutrition. There we have had very good results in practice already. In Finland, food habits have approached dietary recommendations during the last decades, and at the same time also socioeconomic differences have diminished, and even though there still are some challenges, but however very good development. The Finnish food and nutrition policy has been universalistic, so the target has been the whole population, not any specific groups, and these universalistic measures seems to be more effective in the lowest socioeconomic groups. And for example, pricing of food and availability of healthy food. Good examples, mass catering, so that healthy meals are available in workplaces and there are subsidies given for employers to provide that. And schools where free meals, healthy meals are provided for all children. And health as a separate subject in schools' curricula, so that also there nutritional issues are taken up. And we have good examples of partnerships with industry in product development, so that labeling, low-fat and salt products are available, etc. And also cooperation with NGOs. Another area, issue-based area, there are good results is on multi-sectoral cooperation is prevention of injuries. Their results can be seen rather soon, and injuries are more common in lower socioeconomic groups. So another example. But if you take this kind of issues-based approach, it shouldn't be too narrow, so that it should have a broad approach as well. Another issue I would like to raise is cooperation. Cooperation on European level, cooperation nationally, of course, so that we can learn from each other. So that's something we can compare how we are doing, what we are doing well, what we are perhaps doing not so well, successes and also failures. There are not always good results of our activities, and we can learn from each other's mistakes as well. And I think this project is an excellent example of how to share experiences. So, based on our experiences, what are the ingredients for success in multi-sectoral cooperation? Long-term commitment and vision. That's something which we need. It's really essential basis. But we need also capacity and expertise on public health, and very strongly, so that we can advocate for health and health equity. And on a very permanent basis created also. We need database, information on trends, development also, what kind of results we have, what are the links between the health outcomes, health determinants and policies. We need health literacy, awareness, very broadly, not only civil servants in all sectors, but also policymakers. While decisions are made, they need to have enough knowledge about issues, but also media and public, which can support the right direction of things if needed. And then we need permanent intersectoral structures, processes and tools, so that there's always available something when we have an issue to take up, to identify the problems and identify the solutions, how to make the decisions, how to implement issues across sectors. Examples of permanent intersectoral structures are, for example, parliamentary or intersectoral committees. We have, for example, on public health, nutrition, physical activity, and different kind of hearings, impact assessments, surely, public health well-being reporting and monitoring intersectorally, and then very practical tools, fact sheets, checklists, etc. And the last one, which we have found important, is legislation. We have in Finland legislation on obligations of municipalities, the local level, on health promotion. They have to take health into account, make health impact assessment, have objectives, cooperation, etc. So that all these elements are there in place. Of course, it's a challenge, and it's not covering all the country yet, but however, development is proceeding. And we are thinking also that we should have such kind of comprehensive set of structures and processes on national level. We are now trying to have this kind of development also with other ministries to create permanent structures and processes for highest political level for all the governments, in planning the programs of the government, in monitoring the development, in implementation, etc. After a couple of weeks, we will have a meeting with all the ministers, permanent secretaries, and the Prime Minister, so that we hope that we get the commitment to continue on this level, because importance of political commitment, it's something which can't be emphasized enough. Just shortly, there's a lot of going on in Finland and in many countries as well. Nothing is perfect. We have still a lot to do.
Thank you very much. I mean, I took many things from that, but one was just this sense of you've got to have a multifaceted approach that isn't just one intervention, that it's got to be comprehensive. And thank you for taking us through all those different tools and mechanisms. Now, turning then to John Ryan, who you met earlier in the day. And John, I think you've obviously, from a European Union perspective, got an oversight of all the member states. So could you just give us some insights in terms of what you found has worked in terms of getting that cross-government commitment and making some of these policies a reality on the ground?
Thank you very much, ladies and gentlemen, ministers. I'd first of all like to apologise on behalf of my Director General, Paola Testori-Coggi, who was supposed to be here this afternoon but was unable to participate because of another event. And I'd like to say a few words on behalf of the European Commission at this stage in the conference, because I think we have now had a very, very good overview of the activities of this joint action, and it might be a good time just to reflect on some of the elements which would be needed to take forward this work. I myself have been very impressed and almost fascinated by listening to the practical examples of initiatives on health inequalities which have been developed by the partners in this joint action and which have been presented to us earlier on today. I've also been proud of the commitment of several ministers and secretaries of state who have made the effort to come along to show political ownership of this topic. This is unusual enough to be underlined, I would say. And I would also like to underline the obvious enthusiasm shown by civil servants in the room, by representatives of health professional organisations, by industry representatives who haven't spoken so far but who are here, and also by NGO groups which also support this goal of reducing health inequalities in one way or another. I found a very strong appetite in the room for doing more on the issue of health inequalities, and a real groundswell of opinion in favour of continuing to focus on the issue of health inequalities. Reducing health inequalities is also a top priority, I would say, as member states face a financial crisis in many cases, in order to develop more sustainable health systems. And I think it's very important that we integrate the needs of vulnerable groups before rather than after and in this reform process. It's very clear to me that governments have a central role in this process, in making this happen. However, the involvement of patients, for example, and citizens through improved health prevention, through empowerment, through information and health literacy, I think is also a key element of success. Secondly, several speakers in the morning session, and also my colleague from Finland just now, mentioned the importance and the power of health data. And I think we can use probably more intelligently what we know about the unacceptable facts about health inequalities as arguments to make changes in policies across government. Thirdly, I would stress that governments should not try to solve this issue at the level of health ministries or indeed on their own. I think there are unbeatable alliances which can be created between governments, business and industry, health professionals and civil society organisations. And I would just quote the example which I saw for myself yesterday of the Europe Against Cancer initiative, which has been existing at European level since the 1990s. And I would say it has been an example of success in the sense that it brought together governments, civil society and health professionals in moving forward a whole series of initiatives on cancer control in Europe, which probably wouldn't have happened otherwise. For example, the initiatives we've taken on tobacco control legislation or on screening for cancer have been examples of where governments acting on their own would not have achieved the same success. And finally, I'd like to encourage perhaps a more integrated look at health inequalities when developing public health policies. For example, as I speak, we are developing and finalising with the Greek presidency and the help of the outgoing Irish presidency a childhood obesity action plan. We're also working on renewing the HIV/AIDS action plan. And I think it's very important that when these types of policy initiatives are being taken at the EU level, that we look specifically at how we should address health inequalities when we're revising the policies or when we're drawing up new policies. Another example is the forthcoming conference which is being organised by the Commission on fairness or discrimination in health. And I think this will also be an occasion to highlight those groups in society or those issues which need to be specially looked at and specially protected in terms of discrimination, stigma and economic deprivation, because these are very often cumulative and a real brake on human and economic development. Thank you very much.
Thank you, John. You've given some really clear potential ways forward there for taking forward the work beyond the Equity Action Programme. I'd like to now just move to the floor and take a few questions and points on what you've heard, and then I've just got a few things to say before we close for the break. So yes, the lady about halfway back has got two fingers in the air.
Well, thank you to the speakers for setting out so clearly some of the things that really need to be done, particularly by governments, or can be done, are being done to address health inequalities. What struck me, I think we've heard all day that the health sector and the health ministries can't do this on their own, and that they need to convince other sectors, or other sectors need to get on board too, but that health inequalities, either other sectors lack awareness or it's simply not a priority. So within the health ministry we need more capacity. I think as was said by Taru, Koivisto, and I think it's very important to underline the need for capacity also. And so I was just curious how in Finland have these capacities within the Ministry of Health. What have you done to start developing these capacities? And then more generally, is there a move within other ministries maybe also to start taking this approach to work with other sectors? Because it's not, as was also said, it's not inevitable by any means, and it does require very new ways of working and a reorientation of funding also within the ministries on how, on what staff do and how they work. So I was just curious to hear a bit more about that.
Very good. Why don't we take that one straight away, because it's specific.
All right, yeah, thank you. Perhaps in Finland we are in a very good position, therefore, that we have had good capacity in the ministry for a long time. And in addition, what's most valuable for us, we have a National Institute for Welfare and Health, which provides the database, expertise, research, development, everything. It's available, and it has been developed for a long time, stronger and stronger. Now we are just now, actually have to say, in a difficult situation because of financial difficulties and cuts to be seen in near future, and a little bit worried about the future as well. So perhaps I can't answer how to create and how to strengthen, because we are proud we have this. This is very important. And then you asked about how the other ministries' role. We have had these intersectoral committees and cooperation with other ministries, but we are just now trying to, or tried for some time to increase this cooperation, and especially I mentioned the material which our National Institute is producing for them to use, and data for them to use. And we are trying to create different kind of forms to cooperation. So, for example, now when we are preparing for the background information for next government's program, we are not doing it separately, but we are doing it together, so that we can have common views there provided for the discussions in the future. So it's just starting with one example. We have a lot of common issues with which we can, on issues based, start cooperating.
Thank you. Let me just take a couple more questions, and John Ryan would like to come in after that. So I'm going to do a couple at the back. There's always a danger that people at the back get missed out. So right at the back on the right, with the pencil in the air, and then even further back, almost by the window. Yes, is that good? Okay.
Yeah, Fritz Schröder-Senker from Mars Incorporated. First, thanks, Mr. Ryan, for the invitation to speak up as an industry representative here. I'm happy to take that on board. So I have a question mainly to Mrs. Koivisto regarding involving industry into a multi-stakeholder approach. So I guess you are not very surprised, Mrs. Koivisto, that not everyone is always happy to involve industry in those multi-stakeholder partnerships. So therefore, you have your own experience here. So what are your learnings? What in the end are conditions that those partnerships or those multi-stakeholder activities involved, including industry, can be successful?
Thank you. Now, just hold on answering while I just take the other question right at the back, if that's okay. So, lady right at the back. Yes, you. Yep.
My name is Evelyn Nusalim from, I'm consultant from the Netherlands. My question is for Mr. Decoster, because I understand that Belgium has different communities based on different languages, and that the policies in the different community is quite different. And so how can you combating the inequalities if patients come and they don't speak the same languages with the health services, and they will already discriminated? So how can you have the national working group doing these inequalities?
Very good. So why don't we take that question first, Christiaan, and then we'll turn to Taru.
Well, first of all, we work very well together with our other regions. We have an inter-minister conference with coming together 2-3 times a year. We have different working groups, and they are making what we call protocols, agreements, and that is going very well. Each year we have different protocols, agreement about different actions and issues. So we have presented our plan about health in all and inequalities, and there was an agreement. Is there a kind of discrimination between language? No. Each region has its own language. We have the special region of Brussels, but there is they are treated, the two language groups are treated on the same way, so there is no problem on that level. What we are trying to do now is to make a plan about inequalities and to present the plan to the Inter-Minister Conference. And I'm sure that we will have results. The working group is started. They have different issues they are discussing now, and I'm sure that we will have a plan at the end of the year. But I cannot say that there is a kind of discrimination between language.
Yes, thank you. Very good question concerning the involvement of industry. I think Finland is one of the most careful countries in international cooperation concerning the cooperation with industry, and that also in our national policy. Ministry itself doesn't cooperate with them, but we have on local level, for example, bakeries are producing bread with less salt content, and our NGOs, which are a very strong role in Finland, have projects on half health or something like that. So they have, in a way, committed how to cooperate so that, for example, some products can have a heart label or this kind of approaches. And our National Institute also somehow is involved there. But as I said, we are really careful so that there are any question marks raised about the situation. But there are some situations where there are benefits for both sides, and these have been the balanced way also considered.
John, just before you come in, could I ask you a question as well? I think everybody in the room will have been really encouraged today by two things, actually. One is every representative of a national government who's spoken today has given a really clear statement about strategy and activities, and there is clearly momentum. And similarly at the Commission level, the European Union level, we've seen how this approach to health inequalities is beginning to infiltrate wider social policy and also use of structural funds and so on. What I'm not clear about yet today is how the two tie together going forwards. So before the Equity Action Programme, we had the expert group, but there wasn't really the same level of collaboration and influence on policy development. And now the Equity Action Programme is coming to an end. I'd just be interested in your views on what you think is going to tie this together and ensure we still get all the benefits of collaboration that we've had from the programme.
Maybe I deal with your question first, since it's freshest. Let me say that the Commission at the moment is looking with the Member States to see how this action on equity action can be continued. Not necessarily with the same partners, not necessarily in the same structure, but the idea of how to take forward the initiative, or the idea of reducing health inequalities, is not something which we can put to one side and say that's dealt with, it's done. That's clearly not the case. One of the challenges for me are the little flags you see on the left-hand side of the screen, because it seems rather strange to me that we only have 14 flags there rather than 28 or 29, and that would be, for me, the first thing that we should be looking at, to see how we could actually extend the geographical involvement of other Member States or other regions, to learn from the results and to benefit from the initiative which has already been taken in the framework of the current joint action. So we're looking very actively, and I understand there will be a meeting with the Member States tomorrow in order to see exactly how this can be taken forward. But very much in terms not of business as usual, but I would say of an expansion and reinforcement would be what we would be looking for. Second point, in terms of cross-government understanding. Here I have some personal experience, because my own background is from taxation and law, and I arrived in the health department of the Commission, and I was considered like an alien when I arrived. I was given the tobacco file to deal with, but in fact it was far easier for me as a lawyer or as a tax person to deal with the tobacco file than it would have been for a medical profession, because I was really looking at the issue from the outside. And therefore I think it's very important that we don't only build a specialisation in public health, but we also encourage movement between government departments and develop expertise on health in other community or in other policy areas, in order that the message is not only contained in one ministry but is spread across government. I think that's perhaps one way that we can improve our impact. I know that within the Commission, trying to convince colleagues who are specialists on the internal market or specialists on competition law of the public health argument is often very difficult. And my Finnish colleague mentioned the importance of health impact assessment. And this is very often where we come up against the lack of understanding in other departments about really what the health impacts of policies are. Taxation is a good example, where you can come up with figures, but unless they're presented in a convincing way and you're able to argue also on a legal aspect, the health arguments will not generally win the day. Concerning the involvement of industry and business more generally, I think we have some good practice examples as well in terms of workplace health promotion. And I would just mention the example of workplace health promotion as a model at the European level, which has been shown to produce good results in terms of alcohol abuse prevention in the workplace, improving nutrition of employees, but also reducing depression and improving people's mental health. So I think there are examples where we can involve business and industry in public health objectives and thereby improve the quality of life of workers in the workplace. And it's really a win-win situation from that point of view.
Thank you for that. We've got time for probably two more questions, if anybody has got a question. Yes, just over here on the right-hand side. Is there one more? And right at the back. So you first.
We are a patient organization, the ME Association, and we are the ones that benefit from the health equity actions. But what we see is that it takes quite a while to get to us. So it's that the patients wonder if it keeps so long for the government policies that they issue to get to the patient, because we keep waiting.
Thank you. And the question at the back, and then I'll give the panel the last word.
John Winoden from the UK Health Forum. This is about, so where does this go in the longer term? And I know you were saying let's put some more flags on that chart, but I would say that we actually need to look at this equity in action in the light of the recent report of the high-level panel on the post-2015 agenda, because the outcome of the discussion at the UN General Assembly is about making the case for new global partnerships to eradicate poverty and transform economies through sustainable development. And the panel's 5 transformative shifts, which include leaving no one behind, putting sustainable development at the core, transforming economies for jobs and inclusive growth, building peace and effective, open, accountable institutions for all, forging new partnerships. In other words, it's no longer solely an agenda for developing countries. It's universal, and all countries will be included, and will place new demands on everyone to mobilize social, economic and environmental action to ensure healthy lives. So it seems to me that whatever is achieved in the final documentation about health and well-being at home and internationally will be a potential lens by which we can actually gauge progress for all countries. This will enforce the political imperative to tackle equity in action in all settings, local, regional, globally.
Thank you for that. What I'm going to do is a really important intervention, because it's the first time today that we've really connected to the global agenda. What I'm going to do is not try to answer that now in a very short amount of time. I'm going to ask Michael Marmot, when he does his comments at the end, whether he might just give some reflections on how the European and global agendas tie together, if that's okay, Michael. And then I'm going to ask the panel if they'd just like to say a final word each on this question about how do you ensure that the benefits of government intervention reach patients in terms of tangible gains as quickly as possible? So maybe Mr. Costa first.
It is very important to work together with patients' organizations. We are doing it in different issues already in Belgium. So it's a good suggestion also for our working group on health inequalities to take them also on board and to hear them, so that they are directly related to the action plan that we will make.
Thank you. Taru?
NGOs and patient organizations and other civil society groups are very important partners in all parts of implementation of health and health policies. I don't know if I have very much to add to the previous speaker.
And finally, John.
I think the regular contact with health professionals, with NGO groups, and also the role of national and the European Parliament are very important in highlighting these gaps in treatment, or gaps in prevention, or gaps in screening, for example. We had some examples this morning which were quoted, and I think this is one way that governments can keep on their radar screen whether the policies are being implemented in practice or whether there are gaps. On the issue of sustainable development and inclusive growth, there has been a discussion launched by the Council of Ministers on sustainable health systems. This is being fuelled also by the financial situation, the financial crisis in some member states. And the Commission will be organising very shortly a summit on chronic diseases, prevention and management. And I think this will be one of the challenges of the years to come, the issue of the epidemic of certain chronic diseases and how national health systems will be able to cope with that. This will put even greater challenges on the financial sustainability of the systems and may encourage greater inequalities unless this aspect is included from the very beginning. Thank you.
Thank you. So, first of all, could we just give a big round of applause to our panellists, please? I don't know about you, but I was really encouraged about what John Ryan said about a greater EU commitment and involving all member states to take forward the work on inequalities, and we will all wait to see what comes out of the discussion between the member states. 3 points from me. One is, before maybe the next session or at the end of the day, it'd be worth all of you going in your packs to the manifesto which the Equity Action Programme has published at the end of its time, because on the back is its own views on what the checklist for action should be for member states, for regions, for the European Union and for the European Union member states working together, and they're really sound proposals. The second is to notice from the European Commission themselves that anybody attending the expert working group meeting tomorrow who has not yet signed the attendance list, could you please visit the DG Sanko stand in the lobby area during this break we're about to take. And finally, this will be a good time to start thinking about filling in your feedback forms and remembering that for each one we fill in, the Hospice in Wales gains €2 towards its work. We're due back at 4:25, so grab yourself a cup of tea or coffee, and then we'll have the final session on the future of research. Thank you.